ICD implantation, to name a few. Sir will be discussing on clinical overview of granulomatous myocarditis. Welcome to you, sir.
Oh, thank you very much for the generous introduction. I would like to thank both Sharmila and Priya for joining us. This is an evolving area, and there are a lot of unanswered questions. And I'm just going to briefly present the clinician's point of view in dealing with granulomatous myocarditis. And we kind of stumbled upon this almost 2 decades ago when some of the patients with so-called idiopathic ventricular tachycardia didn't behave the way it was described in the textbooks or in the journals. They had a higher incidence of progression, and some of them died suddenly. That made us look deeply into this entity. So why is this entity of granulomatous myocarditis relevant? I think it's far more common than what we think. Secondly, very often the diagnosis is delayed, which results in increased morbidity and mortality, even to the point of missing a diagnosis and ending up in a cardiac transplant or an LVAD. This is a disease of remission and relapses, so close follow-up is required, just like when you follow patients with malignancy when there's a recurrence later on after chemotherapy. And there is no consensus on management. And the mainstay of therapy, at least for cardiac sarcoid, is steroids, and it's associated with significant side effects. We find that it's a lot more among people with poor build, who have lean muscle, lean body mass, where the muscle mass is poor. They tend to have a lot more of side effects. And this conundrum, diagnostic conundrum of paucibacillary tuberculosis, which presents with symptoms and signs very similar to sarcoid, and therefore there is an overlap syndrome in a group of these patients. This is the epidemiology of both tuberculosis and sarcoid. On the right, you have a very high, the map showing a high prevalence of tuberculosis. Wherever tuberculosis has been wiped out in Europe, Scandinavian countries, there is a very high prevalence of cardiac sarcoid. Now, let us start with there's no better example than to start with a case. This is a 14-year-old boy with monomorphic VT, normal heart function, had this form of rapid ventricular tachycardia, which was successfully ablated. And post-ablation, this patient undergoes detailed evaluation, including a treadmill, repeat EP study. Everything was normal. And they could not induce any VT despite aggressive stimulation. And then everything went on fine. And then 10 months later, this was the diagnosis made, giant cell and a granuloma. But unfortunately, this was post-mortem. This boy died suddenly, and post-mortem revealed a granuloma in the interventricular septum, which most probably was the cause of sudden cardiac death in this patient. This is one of our own patient who underwent a similar story. He undergoes a successful catheter ablation of outflow tract VT. And we thought all is well, and we sent him home after a review. And 2 years later, collapses at home, comes back with poor LV function and a LV thrombus. This is another thing that we find. There is a higher prevalence of left ventricular thrombus in these patients. We have recently reported this as one of the causes of embolic stroke in a large proportion of cardiac sarcoid. And biopsy confirmed that this person had a caseation and a granuloma from the mediastinal node, and this was ringed by giant cells, and a diagnosis of tuberculous myocarditis was considered, and he was started on appropriate therapy with significant improvement. Now, let me just tell you the cost of misdiagnosis. This is a lady, an IAS officer's mother in Delhi, goes to one of the premier institutes in 1996, and idiopathic BT, treated with amiodarone beta blocker, has resuscitated the sudden death and LV dysfunction. ICD was implanted, and then again this was upgraded to CRTD, and we got to see this patient. These episodes like 2004 and later on, the procedures were done in the US, and we saw the patient in 2009 when we picked up a small node and the diagnosis of cardiac sarcoid was made. Now, the reason I am presenting this is the disease of a smoldering presentation over decades, and we don't know why some people have such malignant course and some people have a very chronic indolent course with variable systemic symptoms accompanied by remissions and relapses. To backtrack, what happens is, we have all learned this in medical school, that when there is an immune system that mounts a defense response, it clears the antigen, all is well. The bacterial infection, staph, streptococcus, you get rid of the organism, everything is fine. But there are occasional instances the body is not able to get rid of either the dead bacteria, fungi, or a foreign body like a suture material, talc, whatever it is. And these substances, even though they are retained in the body, there is an attempt to wall off these antigens by an aggregation of macrophages that forms in response to chronic inflammation, and it walls off this material in a tight fitting granuloma. So we don't know why this happens, but there is a clue that some of us are intrinsically prone because there are certain HLA determinants, PTNL2, annexin A11. These are genetic determinants why some people more often develop sarcoid-like reaction. So typically what happens is, suppose a metal or a foreign body enters the lung or heart. This is picked up by the antigen presenting cells, presented to native CD4 cells, which results in a clonal proliferation of the similar CD4 cell, which mounts a response against this intrinsic antigen, and they try to wall off by producing a granuloma. There are two consequences. One is the antigen is cleared and then it shifts towards Th2 response, or there is a very exuberant fibrotic reaction, and this is where you develop a fibrotic lung, ILD, where the lung becomes completely fibrosed, or the patient develops severe cardiomyopathy ending up in a transplant. So there is exuberant fibrosis, and depending on the organ of involvement, there is a collateral damage either to the lung or to the heart, resulting in severe organ dysfunction. So what is the clinical presentation? At least in most of the patients that we ever come across, there is a little bit of a referral bias compared to what we have seen in the literature. Unlike most of the patients who had cardiac involvement as a part of systemic sarcoidosis, ours is predominantly patients with cardiac symptoms who present with unexplained AV block, ventricular arrhythmia, or unexplained heart failure, idiopathic LV aneurysm. Phenotypes like valvular heart disease have been noted in this disease entity. Certain clues to the clinician is if there is a family history that tells you there is a genetic predisposition, frequent nodules in the shin, for example, erythema nodosum, past history of a facial nerve palsy, or an adult onset of bronchial asthma or respiratory disease coexist and should make you suspect that there is something else going on in addition to cardiac findings. This was the initial presentation a couple of years ago we made, that there is a discrepancy between the areas where PET lights up and the MRI showing a scar, showing that there is a complementary information from MRI and PET. PET tends to light up in areas of inflammation, whereas MRI picks up a little more later stage of chronic fibrotic form of disease. and we are more interested in picking up the inflammatory phase of the disease. This is quite relevant in patient management. For example, in this patient where there is intense PET uptake in one localized segment, but no scar on MRI, if you adequately treat this patient, you may completely have a complete resolution of the cardiac inflammation with no sequelae, and there may not be a residual scar. In contrast, if you have a person with predominant scar, then the treatment may be more mechanistic treatment like catheter ablation devices and other forms of therapy, and there may not be a role for immunosuppression. The other thing we noticed was, in contrast to a signature of a monomorphic ventricular tachycardia, we noticed that some degree of pleomorphism indicates active disease and active inflammation in multiple areas of the heart. So this is called monomorphic VT, where the beat to beat to beat morphology is similar, whereas when you have 2 or 3 different morphologies going simultaneously, that is pleomorphism, and that seems to predict ongoing inflammation in some patients with cardiac sarcoma. Now, is this true only of ventricular arrhythmia? No. All of you would have, as a medical student, if a person has a symptomatic AV block, the treatment is just giving a pacemaker and leaving him alone. Whereas in this subset of AV block, approximately 30% of them have an abnormal PET uptake when you take unexplained AV block. And why is this relevant? Because these patients have progressive disease in terms of LV dysfunction, frequent ventricular tachycardia, ultimately culminating in either refractory heart failure or death. So patients who go for a pacemaker implantation, if they are between 30 and 60 years of age, we started evaluating them. And whenever we find PET is abnormal in focal areas, there is a higher incidence of ventricular arrhythmia or heart failure or mortality on follow-up. So again, this is another way the disease presents. There are certain electrocardiographic clues. One is if you find fascicular blocks and QRS notching, that seems to predict the occurrence of, the presence of inflammation in the myocardium. In India, you can never forget tuberculosis, because we take all precautions to evaluate these patients in detail, including gene expert or TB PCR from the tissue. And in case there is slightest doubt that there is a mycobacterial antigen in the tissue, we treat them with antituberculous therapy. On the other hand, if you have patients with no evidence of mycobacterial antigen and a non-caseating granuloma, we treat them adequately with immunosuppression. This is taken from Buffman from Lancet, how they treat lung disease initially with prednisolone, escalating immunosuppression. And it's very similar treatment regime we follow. When we treat these patients adequately, we find there is a dramatic decline in the occurrence of ventricular arrhythmia. Frequency comes down, and most of them do very well with adequate immunosuppressive therapy, provided you treat them early on in the course of the disease. And we have been traditionally using repeat scan at the end of anywhere from 3 to 4 months to monitor the disease progression, because several of them with adequate therapy, there's complete resolution of the both myocardial and lymph nodal uptake. But to our surprise, we found that uniformly, the lymph node, even when it comes down, in a proportion of patients, when the myocardial uptake remains persistently elevated or it increases on treatment, these patients have more adverse events in terms of progression of LV function, dysfunction, or recurrent VT. And this steroid resistant form of cardiac sarcoid, we tend to escalate the immunosuppression quite early on in the course of the disease. Again, once you have excluded adequately that there is no inflammation, then only we consider more mechanical options like catheter ablation of ventricular tachycardia. We do not proceed with the catheter ablation if there is any evidence of inflammation in the myocardium. So broadly, we have 3 patterns of disease. One is a patient, this is a group A, where patients predominantly present early on with very frequent ventricular tachycardias. With adequate therapy with glucocorticosteroids and others, there is a dramatic decline in VT and all is well. Some of them come back with late recurrences, but this recurrence is more related to fibrosis of the myocardium, and here we offer catheter ablation. But some patients, when they have a recurrence, it's because of recurrence of cardiac thoracoid reactivation. Here we escalate the immunosuppression to suppress the underlying cardiac inflammation. Again, as I said, some of the ECG clues are telltale evidence of fractionation and axis shifts. And another classical sign is the basal septum, when it fails to thicken in systole, that's a very early marker of cardiac sarcoid in these patients. I would like to thank my colleagues who have been instrumental in running the sarcoid clinic along with the rheumatologist. And just to conclude, granulomatous myocarditis is very widely prevalent but under-recognized. Diagnosis is often delayed. It results in unexplained ventricular arrhythmias, AV block, with or without cardiomyopathy-like presentation. The main problem is the physician's cognitive bias. There is no constitutional symptoms. ESR is normal, ACE levels are normal, no weight loss, and therefore we are not conditioned to think of an inflammation. But that's how this disease presents, and lack of awareness results in delayed diagnosis in several of our patients. This is a relatively common cause of unexplained AV block and ventricular arrhythmia, and it remains a treatable cause of ventricular arrhythmia and a preventable form of cardiomyopathy. Thank you very much.
Thank you for the wonderful presentation, sir. Now I invite Dr. Sharmila Durbala, Professor of Nuclear Cardiology and Radiology, Brigham and Women's Hospital, Boston. She was the President of American Society of Nuclear Cardiology for the year 2020. She served as Board of Directors, held various positions, and participated in numerous committees, including Education and Finance. She chaired the writing groups for two recent guidelines, which are SPECT Imaging Guidelines and ASNC Expert Consensus Recommendations for Multimodality Imaging in Cardiac Amyloidosis, which was published last year. She will be discussing about the nuclear medicine imaging in granulomatous myocarditis. I invite Dr. Sharmila.
Sorry, are you able to see my screen?
Yes.
Yeah.
Yeah, sorry, I was muted. So I gave a live talk, right?
That's right.
Okay, perfect. Thank you. Thank you. Hi, good afternoon, everyone. I'm really pleased to be here to discuss with you about cardiac sarcoidosis. Really an honor to follow Dr. Narasimhan's excellent presentation on the clinical manifestations of cardiac sarcoidosis and how imaging can be used to change management in these patients. So sarcoidosis, as you heard, is a systemic granulomatous disease, and it tends to affect the heart. Isolated cardiac involvement is rare, and it's frequently underdiagnosed. And endomyocardial biopsy, as you can imagine, has a low diagnostic yield, less than 20%. And this is mainly because it's a patchy disease, and biopsy typically targets the right side of the interventricular septum. Heart block and ventricular tachyarrhythmia and sudden death may be common presenting signs and symptoms, and early diagnosis is important because it may improve prognosis in these patients. So for an infiltrative cardiomyopathy, one would expect that endomyocardial biopsy would be a good approach, but it has some challenges. So here's an image of an explanted heart taken from a patient who underwent cardiac transplantation. So depending on where you sample this heart, we may find typical granulomatous inflammation consistent with sarcoidosis, fibrosis, non-specific inflammation, or even normal myocardium. So the challenges with RV biopsy are sampling error, biopsying the right side of the septum, because the disease very often affects the left side and infralateral wall of the left side, and that could be potentially missed by RV biopsy. Of course, it's an invasive procedure, and because we randomly sample here, it's not quantitative. Response to therapy cannot be assessed because we can't, because actually it's not helpful. First of all, it's invasive, and what you biopsy may not really reflect changes in the entire heart. And the last important factor is we know from cancer literature that when you treat cancers, the metabolic changes in the tissue may occur before there's an overt structural change. So for all of these reasons, endomyocardial biopsy is limited, and imaging provides not only a whole heart image, but even a whole body image in situations like cardiac sarcoidosis. So let me start off with a case. So 49-year-old man with history of lymph node biopsy, proven sarcoidosis, comes in for evaluation of syncope. His syncope story was not very clear. It happened on a night of heavy drinking. He had no sleep. He did complain of some prodrome, and this happened while he was seated at a table. And it was a brief self-terminating episode. He woke up spontaneously with no trauma. He has a past history of paroxysmal atrial fibrillation. Most of his testing was negative. Stress testing, ECG, echo, cardiopulmonary testing, Holter, and cardiac telemetry showed a narrow complex tachycardia with AV-NRT. So the primary question for us is, does this man have cardiac sarcoidosis? Do we think yes, no, or need more information? So his team felt they needed more information. And what do the guidelines say? So the guidelines say that we could diagnose sarcoid either by an endomyocardial biopsy or by an extracardiac biopsy with one or more of these features: steroid or immunosuppressant responsive cardiomyopathy, unexplained LVEF reduction, unexplained sustained VT, heart block, and then typical features on PET, MRI, or on a gallium scan, of course, when all other causes for these manifestations have been excluded. So where does our patient fall in this? So if you look at the guidelines, our patient presents with palpitations and syncope. So this is taken from the Society of Nuclear Medicine and Asthma guidelines, and on the right side is the Heart Rhythm Society guidelines. So both of them have given us various scenarios where you may consider further imaging. So in patients with histologic evidence of extracardiac sarcoid, then if they have unexplained palpitations or syncope, they become candidates for further imaging. Same thing with the Heart Rhythm Society, biopsy-proven sarcoidosis, either symptoms, abnormal ECG, or echo. You have one or more of those, you could consider advanced imaging. So this patient was brought in, and before I go there, let me go into this. So what is the first test, whether it's PET or MR? So this is taken from the EANM ASNIC guidelines. So in patients with suspected cardiac sarcoidosis with symptoms or abnormal changes, CMR is the preferred first test. And this is also our practice at Brigham and Women's Hospital. We usually perform cardiac magnetic resonance imaging with gadolinium. If that is normal, then you just follow the patient clinically. If CMR is abnormal, unavailable, or contraindicated, then we might proceed with FDG PET-CT, which typically includes a perfusion scan with it. Important to note that in some patients, even if the CMR is normal, we may consider FDG PET if the clinical suspicion of sarcoidosis remains high. Then, of course, as you just heard, with patients who have FTG or MRI, if the FTG is positive, suggesting inflammation, they become candidates for advanced therapy. If the FTG is negative, but there's a perfusion defect or late gadolinium enhancement, then those patients may become candidates for ICD. So this is our patient's MRI study. You can see no late gadolinium enhancement, excellent quality MRI, function is normal, and edema imaging showed no edema. So at this point, CMR is a clean negative study. Is sarcoidosis excluded? Yes, no, or need more information? So here's where we start talking to the team, and the clinician felt, given the syncope and the biopsy-proven extracardiac sarcoid, they needed more information. So this patient was referred for an FTG PET study. So this is our protocol for FTG PET. It's typically a 2-day protocol. Day 1 is dietary preparation. Day 2 is imaging. Our diet is high-fat, low-carbohydrate diet for 24 hours, followed by a long fast, overnight fast, 8 to 12 hours. There's emerging literature suggesting that a longer period of fast, even 72 hours of ketogenic diet, may be even better. When they arrive the next day, we perform a perfusion study, either SPECT-CT or PET perfusion imaging, followed by injection of FTG. 5 to 10 millicuries of FTG, 90 minutes of wait period. We do obtain cardiac images, followed by partial body images. Remember, sarcoidosis is a systemic disease, so partial body images are extremely important, and our field goes from kidney to the top of the brain. So this is a recent publication in JNM that's just on their website, suggesting that in patients who got 72-hour ketogenic diet compared to 24-hour, complete myocardial suppression was much more prevalent. Failed suppression was almost essentially absent. Therefore, we may eventually see a change or shift towards that. So when you perform your perfusion and FTG images, there's certain classic patterns that we may notice in these patients. So here you see on top, perfusion imaging, short axis. In the second row, FTG imaging. On the left side, you see a normal perfusion with no myocardial FTG uptake in column A. This is a normal, completely negative. At the right end, you see F. And in F column, you see fibrosis, perfusion defect, inferior infralateral, no myocardial FTG uptake. This is blood pool. This is fibrosis. What about D and E? D and E show a perfusion defect, infralateral perfusion defect in D and septal perfusion defect in E. So when you see a perfusion defect and when there is a concomitant mismatch, focal increase in FTG uptake, these patterns are consistent with focal myocardial inflammation and in the right clinical context may represent active cardiac sarcoidosis. So what about B and C? So B and C are scenarios where the perfusion is completely normal, and in B you see complete diffuse FTG uptake. So this is a non-specific imaging finding. This cannot be interpreted as sarcoidosis or inflammation. And the C is where you have no perfusion defects but infralateral uptake. In our experience, this is not specific for inflammation. For some reason, the lateral wall of the myocardium is much more difficult to suppress in terms of glucose utilization, physiological glucose utilization. So this is also a non-specific finding. So this is the FTG scan on our patient, perfusion on the top, FTG on the bottom. Here's the whole body showing evidence of systemic disease, but you can see focal uptake in the lateral wall with no perfusion defects. So here's the question again. So how confident are we, that this is inflammation from sarcoidosis? We had a syncope. Is an ICD indicated? Yes, no, need more information. So what are the indications for ICD implantation? So there's class 1 indications where, of course, you have spontaneous sustained ventricular arrhythmias, cardiac arrest, low LVEF, whereas our patient falls, if any, into this class, which would be, it would be useful in patients with cardiac sarcoid independent of ventricular function. Remember, his EF was 65%. If there's an indication for a pacemaker, he doesn't have that. Unexplained syncope or near syncope, maybe. and inducible sustained VT. So now the doctors are now felt with this question of, do we believe that the syncope is arrhythmic in etiology? And they were not convinced. So the question was, what should we do next? So this is the baseline study. Should this patient undergo an EP study looking for inducible ventricular tachyarrhythmias? So after a discussion with the team, the decision was made to repeat the study after 6 months and then proceed, because we expressed our opinion that this looks like a non-specific. We can't exclude a non-specific uptake, specifically given that there's no perfusion defect and MRI was completely normal. So here's the repeat study 6 months later. You can see perfusion looks normal, no FTG uptake, still has systemic activity. So this patient was managed for his systemic sarcoidosis without a device. So what are the classic features of FTG in sarcoidosis? On top is a positive scan, multiple granulomata in the left ventricle and the right ventricle. And after treatment, this on the bottom, you see a negative study with complete resolution of inflammatory activity. So multiple investigators, and in this meta-analysis, have shown the high diagnostic accuracy, area under the curve 0.93 for FTG PET to diagnose cardiac sarcoidosis in relation to clinical criteria based on the Japanese Ministry of Health and Welfare criteria. What about the prognostic utility? Here's data from our lab, published by Ron Blankstein, showing that if both perfusion and FTG are abnormal, these patients have much worse event-free survival. If both are normal, shown in green, much better event-free survival. And if either one of them is abnormal, then you have intermediate outcomes. There's now an emerging interest in quantifying FTG uptake volumetrically on FTG images. Data from Piotr Slomka from Cedars-Sinai, again looking at visual cardiac SUV max or target to background ratio, cardiometabolic activity with LV blood pool value of 1.3 or volume of inflammation. So what he's shown is when you look at a variety of parameters, focus on the green, yellow, and the red. So the green, yellow, and red are basically measures in the myocardium. Is there visual uptake? What is SUV max in the myocardium? And here, using an SUV threshold of 2.7, what is the cardiometabolic activity? What is cardiometabolic activity with an SUV threshold of 4.1? But what they found was, rather than use a relative measure in the myocardium, they found using a target to background ratio, myocardium to blood pool ratio. These are the bars in blue. They said that these group of patients, these group of metrics with target to background ratio had much better diagnostic accuracy. So we may see in future that this may evolve, a target to background type of metric may evolve over SUV in the myocardium metrics. So treatment decisions, as you heard, are guided by imaging, treatment of heart failure, arrhythmia, and heart block, ICD decisions based on EF as well as late gadolinium enhancement. Specific therapy, remember the only specific imaging agent that tells us about inflammation in the myocardium is FTG PET at this point. Other novel somatostatin receptor agonists have been tried, but those imaging agents have very low signal intensity, and we haven't seen really many studies showing the value of those agents. So FTG PET, our protocol is, even if MRI is classic for sarcoidosis, before we start treatment of these patients, they'll undergo a baseline FTG PET. Fibrosis, if both MR and PET are negative, then these patients don't need anti-inflammatory or immunosuppressive therapy. What about guiding management? Here's the same patient, baseline image on the left, follow-up on the right, perfusion on the top row, and FTG on the second row. The images visually look identical, but when we look at the EF has declined over time. So the question is, how can you tell whether there's disease progression or improvement in this particular case? So again, because this is a hotspot imaging agent, we need to look at SUV metrics or volume of inflammation metrics. And you can clearly see the SUV was higher at baseline, the volume of inflammation was higher, and both of them improved after treatment. How do you explain the drop in EF? So this most likely represents progressive fibrosis in this patient with less amount of inflammation. Although we've noticed, and I'll hear Dr. Narasimhan's opinion, we've seen that diffuse hypokinesis is sometimes the manifestation of these patients, even though they may not have granulomatous disease. So this is a study from the AIG group of hospitals led by Dr. Narasimhan and Dr. Subramaniam, the first author, which is recently published in JACC Imaging. Very important study showing that pre-treatment baseline myocardial FG may be useful to predict immunosuppressive therapy. So here are 4 graphs where they correlated change in LV ejection fraction baseline to follow-up to different metrics. Myocardial uptake index, where they look at SUV multiplied by number of myocardial segments, number of abnormal uptake myocardial segments, and lymph node uptake. As you would imagine, systemic sarcoid activity in the bottom right, this did not necessarily predict change in EF, but all the myocardial metrics, SUV, uptake index, and the number of segments, all 3 of the parameters predicted response to therapy. So the orange is complete responders, green is partial responders, and the blue is non-responders, and you can clearly see a nice response. They also looked at independent predictors of response following immunosuppression, and again showed the same finding. EF and myocardial uptake index were independent and significantly predictive. And in a multivariable model, in a model that included both EF and myocardial uptake index, they showed a high area under the curve, 0.85, for predicting response to therapy. Other investigators are also looking at volumetric measures, cardiometabolic activity, high versus low in predicting outcomes of poor prognosis, and texture. So this is a new measure that's emerging in the oncology field as well as in other areas to look at changes in response to therapy. So these particular investigators from Japan looked at texture metrics. The way texture works is if you put the images into a software, you get 20, 30, 40, a large number of texture metrics. In this particular study, they found that high gray level run emphasis, this particular metric, low, middle, and high tertiles. And you can see that the patients in the low tertile had much worse event-free survival compared to the first and second tertile. So these novel metrics may also play a role eventually. So sarcoidosis guidelines, there are a number of guidelines available. The cardiac PET guidelines by ASLIC has a section on sarcoidosis. The Heart Rhythm Society guidelines has the diagnostic criteria and when to image. The EANM and ASLIC guideline also has data on this. And the SNMMI ASLIC expert consensus guidelines have really great details of when to image, how to use diet in these patients to improve FDG imaging quality. So I want to conclude by saying that FDG PET has emerged as a key diagnostic modality for cardiac sarcoidosis. It provides a virtual histology image of the entire heart and in the whole body. It is helpful because it can detect early disease, repeat imaging is possible, quantitation is possible. We can use FDG to guide biopsy. So in a patient with suspected sarcoidosis without a biopsy, FDG images can tell us which lymph node to target or where to biopsy. And we do hope eventually with more targeted tracer development that biopsy may be replaced by imaging. Management of sarcoidosis, standard therapy once inflammatory activity is detected is immunosuppressive therapy. FDG quantitation, as you saw from the work from the AIG group and other hospitals, is really vital to guide immunosuppressive therapy. Thank you very much for your attention, and I'm happy to take any questions.
Thank you, Dr. Sharmila, for your excellent talk. We have few questions. So the first question is, what is the significance of mild diffuse FDG uptake, maybe the just above the background? Means when you come. So what is the significance of mild increased FDG uptake is just above the background? Shall we take it as a significant or it's just a non-specific one?
I think it's likely non-specific. What we've seen with sarcoidosis is if there's focal myocardial inflammation, there's so much uptake in that focus of inflammation that the rest of the myocardium on the relative images is really kind of normalized against it. So when we do see low grade uptake, I feel it's more likely to be non-specific, particularly when it's diffuse.
What is your experience on gallium dotatate PET CT? Because we are seeing couple of cases where patient can't do fasting, means keto diet. So then what is your role? Can it be a complementary or can we replace in the near future, or more studies are required, and what is your experience regarding that?
Yeah, no, it's an excellent question. I can tell you, so why does FDG show uptake in sarcoidosis? To get back to the bottom question. So FDG not only detects inflammation, it detects hypoxia, it detects ischemia, it detects, cancer in cancer cells, right? It's a non-specific tracer. So what FDG may be telling us in sarcoidosis is not just inflammation, but local tissue microvascular dysfunction or hypoxia from the sarcoid granuloma and its effects on the myocardium. In contrast, the more specific targeted agents like the dotatate and all those are receptor targeting agents. What we've noticed in one small study is that the signal of these tracers appears to be much lower compared to what we see with FDG. So it's highly specific, but maybe giving us less signal. So at this point, I don't have enough experience, and I haven't seen enough in the literature to say that if the FDG is not helpful to proceed with dotatate. I'm curious to hear your experience if you have any in this area.
We have done in around 8 patients where we had a positive result both clinically and also the imaging wise. So we are just in the process. We are planning to do both FDG and DOTA for the same patients. Let's see what it will be. And the other question, yes.
Go ahead.
The other question
We
is,
have many false positive PET focal uptake. What are the causes of false positive focal uptake? Whenever there is no lymph node uptake and there is a focal myocardial uptake, I get a little worried whether it's something which a red array. What is your take?
Yeah, I fully agree. I think isolated cardiac sarcoidosis without histologic proof of sarcoidosis and just a focal uptake in the myocardium is very challenging to interpret. It's likely to represent non-specific uptake more than real uptake. And we know that it exists based on autopsy literature. We know that isolated cardiac sarcoidosis is an entity, but how we diagnose it at this point remains challenging.
And what is the role of perfusion imaging? Is it necessary for all, or it's just like a complementary one, perfusion imaging?
Excellent question. I cannot stress enough the importance of perfusion imaging. Perfusion imaging is extremely important, both at baseline and at follow-up. Why? If you see no FDG uptake in the myocardium, it could represent normal myocardium or fibrosis from sarcoidosis. So let's take a patient who has systemic sarcoidosis. If the perfusion imaging shows focal perfusion defect, or one other point, we are assuming that epicardial coronary artery disease is excluded in all these patients, either by CT-based coronary angiography or invasive angiography, because the mismatch pattern can be seen in hibernating myocardium. So if you assume that LV dysfunction, CAD is excluded, now you see perfusion defects in a patient with systemic sarcoid that likely represents fibrosis from cardiac sarcoid. If you have no perfusion defects and if your FDG is negative, you're likely to miss that. And perfusion is also important to assess response to therapy, because if the patient inflammation is treated and there is a new perfusion defect, then you know that this sarcoid granuloma has evolved into fibrosis. But on the other hand, if you have a patient whose inflammation is treated and the perfusion defect resolves, then you know that this patient has appropriately healed with no residual fibrosis. There's actually an ongoing study in Canada, a multi-site study where they're looking at perfusion defect as an endpoint for treatment response to sarcoidosis. because FTG uptake can be so difficult and challenging with the diet and all. So they have looked at perfusion as an endpoint. Having said that, I must say that in our experience, if we use at least 24 hours of dietary preparation, and maybe with now new data, 72 hours of ketogenic diet with an overnight fast of at least 12 hours, maybe 16 hours, we have seen very few false positives or diffuse uptakes. And I can tell you, to answer Dr. Narsimham's question, when do we see diffuse uptake that cannot be taken care of by diet? These are typically end-stage heart failure patients with very low EF less than 25%, where there is a myopathy. The heart muscle cells are actually metabolically deranged by the underlying myopathy, so they feed on glucose. So it's not inflammation, it's diffuse uptake because of the underlying myopathic process.
Thank you.
Thank you, Dr. Sharmila, for answering our questions. Next is Dr. Priya Jagia. She is the professor in cardiovascular radiology and endovascular interventions, All Indian Institute of Medical Sciences, New Delhi. She is former honorary consultant in cardiac radiology, and she is trained in advances in cardiac CT and MR at Royal Brompton and Harefield Hospital NHS Trust. And her areas of interest are cardiovascular imaging, including CT and MRI, and also vascular interventions. She is the national lead for adult cardiovascular imaging subspecialty for ICRI and also IRIA. And she is the editor for adult cardiovascular imaging volumes of upcoming IRA textbook. She will be discussing on the role of MRI in granulomatous myocarditis. Over to you, Dr. Priya.
Thank you, Dr. Sunita. Thank you for your kind introduction. And I would like to just convey my pleasure at being part of this meeting. It's a privilege to be on the same platform with Dr. Narasimhan and Dr. Sharmila. Now that we have discussed the clinical scenario and also the nuclear imaging, we are going to talk about the cardiac MR in the evaluation of granulomatous myocarditis. Hope my slides are seen well. So when we talk about cardiac MRI in inflammatory cardiomyopathy, why do we choose cardiac MRI as a radiological investigation of choice? The reasons are many. One of them being the cardiac MRI has got its high inherent tissue contrast. So even with non-contrast study, it is possible to visualize edema. So this is a T2 scan, T2 weighted image, which is showing the edema as bright areas. Also, the temporal resolution is very good and allows you to have a functional assessment. This is a ventricle, which is showing diffuse hypokinesia, which is more marked in the anterior and the anterolateral region. Also, it allows you to have the late gadolinium enhancement, which Dr. Sharmila and Dr. Narasimhan also alluded to. So when we talk about LGE, what does it mean? For those of you who are new to this, LGE means that we give gadolinium contrast and we do a cardiac MR after 10 minutes. So any area which is fibrosed retains the contrast and is seen as a bright area. So anything which is bright is actually dead. However, it is edema in the areas where there is edema, where there is increased extracellular volume. Those also could have a bright area. So LG is the way we pick up the fibrosis, and this also helps to prognosticate, because obviously if there is a lot of LG, a lot of fibrosis, the patient is likely to fare poorer. This also helps to differentiate amongst the ischemic and non-ischemic cardiomyopathies also. And now we have newer sequences. We have T1 and T2 mapping, and also ECV mapping is possible, which helps to quantify the edema and fibrosis. So this is taking care of the problems which Dr. Narasimhan talked about. So he talked about the edema which was not picked up on MR, but was picked up on PET. So these newer sequences, especially the T2 mapping sequences, which picks up the edema, have now made it easier, has made MR more accurate for picking up the edema. Also, now we have strain mapping, which allows easy pickup of the diastolic dysfunction before it becomes discernible on the echo. And as you can see, all the major societies have recommended cardiac MR in the work of the patients having inflammatory cardiomyopathy, be it sarcoid, eosinophilic, or lymphocytic cardiomyopathies. And even for the evaluation of the patient while he's on follow-up, this is an investigation of choice. This is something, cardiac MR is a non-invasive modality, involves no radiation, and it gives you a gold standard reference volumes after the functional assessment. So one can use those as baseline for future follow-ups. It is unlike echo, it is an operator-independent technique, and the contrast agents are relatively safe. But however, all said and done, this is something which is not available in most of the hospitals. Having MRI is different from having a person who can do and read cardiac MRs. So availability and cost is another, are the deterrents. Talking about myocarditis, be it viral myocarditis or a giant cell myocarditis, the features remain the same. Approximately 50% of the patients who have ventricular arrhythmias will have active inflammation. And it is the identification of this inflammation which is very difficult, and it is important because approximately 1/4 of these patients will eventually develop cardiomyopathy. And the early diagnosis of this edema, this inflammation is important because that will guide you towards the immunosuppressive, early institution of the immunosuppressive therapy. And if the edema is not there, if there is fibrosis, obviously, then one progresses to the heart failure therapies. So if we talk about cardiac MR in myocarditis, the diagnosis is based on the Lake-Lewis criteria, which was described first in 2009 and then modified in 2018. Also, cardiac MR helps in differentiating this disease entity from the ischemic cardiomyopathy, which commonly mimics myocarditis as far as the symptoms are concerned. And it targets all the three aspects of the myocardial inflammation, namely edema, hyperemia, myocyte necrosis, and also fibrosis. So when we talk about the protocol, it looks at the anatomy, any ventricular enlargement, atrial enlargement, dysfunction. So dysfunction in the form of regional wall motion abnormalities, the volumetric analysis can be done. Edema is a very important component for the evaluation of the inflammatory cardiomyopathies. So we do T2 sequences, and with the advent of the mapping sequences, now it is quantitatively possible to evaluate the fibrosis and quantitate the fibrosis and the edema. So T1 mapping is used to quantify the fibrosis, and T2 mapping is useful for edema evaluation, and ECV can be specifically useful when you have diffuse infiltration. Post-gadolinium perfusion scan to look at the hyperemia is there, and also late gadolinium enhancement, which I alluded to earlier, can be done to pick up the areas of fibrosis. Besides, we always screen the chest for extra cardiac conditions like pericarditis and associated lymphadenopathy in sarcoid patient. So these are the Lake-Lewis criteria. So the main criteria include imaging for the edema and also for the non-ischemic myocardial injury. So on we do T2 mapping or T2 weighted sequences. So what you see is a bright signal on the T2 weighted images and a high T2 value. And as far as non-ischemic myocardial injury is concerned, LG can be seen as bright area in the epicardial region, and abnormal T1 mapping, again, values will give an idea about the fibrosis, specifically useful when you have a diffuse fibrosis. Pericardial effusion can be picked up again as a supportive criteria, and the regional wall motion abnormalities are also picked up on the cardiac MR. And with the 2018 Lake-Lewis criteria, the sensitivity and specificity has improved, with specificity as high as late 90s. So when we talk about myocarditis, so now that we have the mapping sequences, it has been found that the T1 and T2 mapping sequences are the one which have the highest diagnostic accuracy. And amongst these, T1 mapping is the highest, is the most diagnostic, gives the most diagnostic accurate information, followed by LGE and T2 mapping. And as far as the LGE is concerned, the enhancement which we see is typically in the subepicardial region in the lateral wall. And it involves the free wall and may extend to involve the mid wall also. So this edema, like I said, this enhancement, like I said, could be because of edema or because of a replacement fibrosis. So on the follow-ups, if there is reduction in this enhancement, this suggests that this was due to edema and not because of fibrosis. So this can be, the MR can be used to follow up these patients. So you see this edema on the lateral wall in the T2 weighted images, and this LG is corroborating with the same areas. So if you have a LGE which is remaining even after you have instituted the adequate medical therapy, then this could be a sign of fibrosis, and it can act as a substrate for lethal arrhythmias. And if you have an enhancement which is extending from the subepicardial region into the mid-wall, again, this is a poor prognostic feature, and these patients are less likely to have functional recovery. So we have this patient who was a 20-year-old female. This is the scene which I showed you earlier. So you can see there is anterior and anterolateral hypokinesia. The LV is dilated with ejection fraction of 19%. And this is the T2 weighted sequences. So you can see these areas which are showing in deranged map. So it is now possible to quantify and have a value. So this was a 68 plus minus 9 milliseconds was the T2. So this is something which we can use as a reference. And once the patient is started on the immunosuppressive therapy, this can be used, and T2 mapping can be done to see the response to the immunosuppressive therapy. This was the LG image in this patient. So you can see subepicardial bright areas are there, which could be either because of edema or fibrosis. This was a case of myocarditis. Coming to sarcoid, again, we talked earlier, the cardiac involvement is seen in 25% of the cases. However, only 5% of them will be symptomatic. So there is a case for screening patients who have got extracardiac sarcoidosis, but do not have symptoms. Early diagnosis, again, is important, as again talked about earlier, because early institution of corticotherapy will help prevent the malignant arrhythmias and sudden cardiac death. Biopsy, like Dr. Sharmila mentioned, this is sarcoidosis, the results are poor. Though it's a gold standard, the results are poor because of the patchy involvement of the sarcoid. So this is a patient who has got a granuloma. So you can see there is a thickened septum, and there is a granulomatous dark area surrounded by a bright signal suggestive of a granuloma in the septum. So when we talk about cardiac MR, the purpose of cardiac MR is not just diagnose, and that to diagnose as early as possible, but it is also to help prognosticate the patient. And that prognostication is done with the help of the delayed enhancement imaging. Like I told you, the fibrosis, the amount of fibrosis correlates with how the patient responds to the therapy. And we always mention in our report whether there is an associated edema or not, so that the patients can be started on steroids. So it can help direct the physician to the therapy based on the presence of edema. Also, it can, if there are clear-cut features of cardiac sarcoid on MR, coupled with histological diagnosis of extracardiac sarcoid, it will obviate the need for the biopsy. And wherever there are equivocal cases, it can help direct the biopsy. So it can direct the clinician to take the biopsy from the areas which are showing edema or enhancement. And also, cardiac MR can be done to see the response to the treatment. Like I said, you do have baseline volumetric analysis, you do have baseline T1, T2 mapping, which can be used and can be used for the follow-up of the patient. So when we see a patient of sarcoid, this is how we look at the patient. So this is a restrictive pattern of LV function, cardiac function. So what you can see is dilated atria, diastolic dysfunction. This is a classic restrictive pattern of cardiac motion which is seen. One may pick up a granuloma, which may be intramural spotty, most commonly seen in the septal region or in the lateral wall. So this is a granuloma which has been seen as a dark area surrounded by the fibrosis or edema in the late gadolinium enhancement. This is the T2 weighted sequences which can pick up the bright areas because of edema. In addition, we also look at the extracardiac findings like lymphadenopathy, which is seen in this patient. So if we talk about the revised 2016 Japanese Ministry of Health and Welfare criteria, there are 2 out of 5 major criteria have to be satisfied. And out of these 5, 3 of them can be easily picked up on MRI. So you can see a basal thinning of the ventricular septum, or abnormal ventricular wall anatomy, abnormal function less than 50% of the LV, and gadolinium enhancement. These are the major criteria which can be picked up on cardiac. So talking about LGE on cardiac MR, so it is usually patchy, unlike myocarditis, which is more of a diffuse disease. Sarcoid is patchy, shows patchy involvement. So patchy nodular enhancement will be seen and does not conform to an epicardial coronary artery territory. So this is something which we use to differentiate it from ischemic cardiomyopathy. And the enhancement is usually in the subepicardial region or in the mid-myocardial region, as seen in this case, could be transmural also. And LG, which is present in the septal side of the artery. This is something which is classic of sarcoid. And in late stages, one may see features of DCM also. So this is lymphadenopathy, which was present. So the reported sensitivity for cardiac MR is 100% with a specificity of 78%. The spatial resolution and the sensitivity are the high features of cardiac MR. So as far as the prognostic role is concerned, there are multiple studies which have looked at the prognostic role. There is one study which by Smegrima et al., which talked about the LGE being twice as sensitive as the JHM modified criteria to detect the cardiac infarction. And also it was found that the LGE was associated with a 9-fold increased hazard of combined adverse effects and a 11.5-fold increased hazard for the cardiac. Also, it can forecast events. So if you have LGE, which is a potent independent risk factor for death, appropriate ICD therapy, and ventricular arrhythmias. Besides all these prognostic features, cardiac MR can also help detect right-sided ventricular dysfunction, which is present, which may be there because of the elevated right heart pressures, because of the pulmonary sarcoid or RV involvement. So this is a study by Grulich et al., which talked about, again, something which we discussed earlier. So they had 155 consecutive patients who were followed by 2.6 years. And what they found was that when the patient had LGE, the hazard ratio was 31.6. And this was found to be superior to the functional or clinical parameters. So this was something that was interesting. So it was even found superior to be superior to the functional parameters like LV ejection fraction, LV and diastolic volumes, or even presentation as heart rate. And none of the patients who didn't have LGE died or had any event during the follow-ups, even if the ejection fraction was reduced. Talking about the newer T1 and T2 mapping. So again, there are multiple papers which have talked about it. This is the one which had the largest number. So 53 biopsy-proven systemic sarcoid versus 36 normotensive patients were considered, and follow-up MR was also done in 40 patients. And what they found was that in patients who had high ventricular, even these patients had high ventricular volumes, they had a high native T1 and T2 value and a lower strain and ejection fraction. And amongst all the parameters, native T1 and T2 were found to have a higher discriminatory accuracy. And of these also, the native T1 was the independent discriminator between the health and disease. So it helped pick up the lesions quite early with a very good sensitivity and specificity. And in the follow-up cardiac MR, again, there was a significant reduction of the native T1 and T2 in the patients who underwent treatment, making making these measurements effective for in patients who are undergoing follow-ups. So this is a case which is under publication. So we have a patient who is having a thickened lateral wall, and you can see there's a thickened lateral wall here, and this is the diastolic frame and this is a systolic frame. So you can see the basal part is not contracting, so there was basal hypokinesia. So septal and basal septal hypokinesia was there. This was T2 mapping, which was showing a value of 66 millisecond, which was again increased on T2 maps. In T1 map, again, in the lateral wall, there was increased value to the range of 1456 milliseconds. And on the perfusion scan, And on the dynamic scans, you can see these are the perfusion defects which can be picked up. So rest of the myocardium is showing the enhancement, and these are perfusion defects which were seen. Again, in the lateral wall, there was perfusion. And this is the LG image showing the transmural enhancement, late gadolinium enhancement. Again, you can see it in the septal region, sparing the subendocardial region. So subepicardial and transmural enhancement in the late gadolinium enhancement, also extending in the inferior wall. And this patient also had enlarged lymph nodes. So this was a classic case of sarcoid. This is something Dr. Sharmila has also already discussed. So what about patients who are having extra cardiac sarcoid? Should we be doing cardiac MR in them? Yes, if the patient have got symptoms or have got ECG changes suggestive of cardiac involvement, or there is ejection fraction less than 50% as seen on echo, one may consider cardiac MR. And rest has already been discussed with Dr. Sharmila. So this cardiac MR can be used as a for evaluation of patients who have biopsy-proven extracardiac sarcoidosis. Newer techniques have been discussed. Now there are hybrid PET CMR hybrid scanners have been, this is one of the paper which has been published recently. So there is co-registration can be done. Either you can do, like Dr. Rasamantan, he is looking at both PET as well as cardiac MR. Either you can do them as separate study or in a hybrid scanner. One may correlate both cardiac MR as well as the PET, and this will definitely improve the pickup of the inflammation in the patients. So I would like to end by saying that cardiac MR is the screening modality of choice, the radiological modality of choice for picking up inflammatory cardiomyopathy. It not only helps you in early diagnosis, it directs you to the treatment and helps prognosticate the patients. With the newer sequences like mapping, which allow quantitative measurement of the edema as well as fibrosis, and also strain analysis, which again help you pick up early the changes which will be seen later on the echo as discernible LV or RV dysfunction. So all these have improved the cardiac MR accuracy and allow you an early diagnosis. And for the follow-ups also, this is something which can be relied upon because it is operator independent and is totally reproducible. Thank you.
Wonderful images, Priya. Should really congratulate you. One of the best CMR images I've seen.
Thank you.
Congratulations. Have you been using this for patients with devices? Have you been taking them for broadband?
Since 1 year now, we have 1.5 Tesla, though we have 3 scanners, 2 of them are 3 Tesla. So we have insisted on keeping 1.5 Tesla scanner. So we are doing these pacemaker cases on this 1.5 Tesla scanner. We are doing them since 1 year now, yes.
The artifacts do not pose a problem.
No, sir, there are certain changes which we make there are some tweaking of the sequences which we do, and it is possible to do the scans. Not all the sequences are possible. Some artifacts could be there, but reasonably good information can be.
Sunita?
Yeah, hi. Dr. Priya, I just had a question. You showed, I think your second CMR, you showed a hypertrophic.
I'm not able to hear you, dear.
Can you hear me?
No, not
Mutaya,
Sir, can you hear me?
there's some problem with your audio.
I'm not sure, sir. Nothing.
Yeah.
Is it better now?
That's better.
No, that we have a few patients where we have they've been misdiagnosed as hypertrophic cardiomyopathy. So I was wondering if that is your experience as well, or does that mean there's usually a granuloma?
To fix your audio, it's either echoing or something. There's something wrong with your audio.
1 second, sir.
As far as tuberculosis is concerned, Dr. Nasiman, you talked about tuberculosis. We do see a lot of tuberculosis, but we do not usually get them in the early phases. Most of the
Quite late.
involvement is in the obviously in the pericardial region, and we have had few cases wherein we had myocardial inflammation, but they usually presented with extensive fibrosis or wall motion abnormalities, and we did not see much of them in the early phases in the myocarditis.
So the main
I
thing
did
is
not
they have
include-
gone through a phase of inflammation before they fibrose.
Must have. Yes.
And very often they get misdiagnosed. In fact, there's a very recent thing. They have followed up patients who have been treated for tuberculosis. Over the next 3 decades, there's 8-fold higher incidence of sarcoid in these patients. The anti-tuberculous therapy that we give makes their bactericidal, but the mycobacterial proteins remain in the myocardium and they can incite a sarcoid-like reaction. So that's another thing which seems to be a problem.
Is it better?
Matej, has the audio fixed?
RV masses actually, RA mass, SVC
Yes.
mass, tuberculosis, pericarditis. It's more of that rather than myocardial involvement. We do have seen, I would say in last 5 years, I've seen around 6 cases of myocardial involvement, so not many. Though, considering that the amount of tuberculosis we have in our country, so we are not seeing much of, not much of them are coming to us, not many of them.
The other problem is being paucibacillary tuberculosis, it becomes difficult to establish a culture. So unless they have very high sensitive PCR to pick up some mycobacterial antigen, replicative form of MTB may not be seen in these granulomas.
Hi,
Your
Dr.
audio
Jagia.
fixed?
Sharmila here. Can I ask
Hi.
a question, please?
Sure, Dr. Shamila.
Hi, congratulations. Really excellent talk. I learned a lot from your talk and from Dr.
I
Narasimhan's
learned from
talk.
your studio.
Thank you. Really nice to meet you guys, actually, all of you, including, Dr. Sunita Bachu and the entire team at AIG. So my question to you was T2 imaging in sarcoidosis, like how, what do you think about its diagnostic value? How often do you see edema in active sarcoidosis?
See, if you are talking, now we have switched over to T2 mapping since 3-4 years now. So if you ask me prior to T2 mapping era, so the T2 weighted sequences, we always had it out, to be very frank, unless we could see real bright signals, because T2 weighted sequences get a lot of artifacts. So even at the blood myocardium junction, we used to get bright signals. So we were not very confident with them, unless we could see clear-cut bright areas. But now with the T2 mapping, we are very sure. So we clearly mentioned the values, and we actually are publishing papers wherein we had 3 patients who actually, after 6 months of steroid therapy, they showed marked regression of the T2 mapping values. So now I would say I'm quite confident with my T2.
Yeah, that was my next question, actually. Excellent. Thank you.
But
so
that's not
now that
something available at all institutes. It's an expensive.
Yes, I know. But that was my other question, because a lot of times with ICDs, you can't repeat the MRI, but with 1.5T, you are now doing a repeat MR on these patients. Have you seen any regression of LGE in sarcoidosis?
Yes. Probably that paper will come out soon. One of them had a fulminant sort of LGE, and it regressed a lot. It did not go away completely, but like I said, LGE could be because of edema, as well as because of fibrosis. So whether it is because of increased ECV because of edema. So we are doing ECV mapping is something which will be available to us from a week from now. Probably we are getting the license now. So we'll be even more confident when we say this LG is because of edema or because of fibrosis.
Thank you.
But all said and done, it's true that cardiac MR is a very, very specialized branch. It's something which is not, I mean, you need very trained personnel to read
Absolutely.
these images.
Mataya, are you ready?
Yeah.
You
No,
had that question.
I just had a quick
One question I had was to Sharmila or Priya, whosoever. Is it possible that if you have just like a lymph nodal disease, by reflex, if there is interstitial edema, can the myocardium be secondary? I hope, like if you take filariasis or any of those examples, a breast see a lymphedema following a mastectomy and patient has lymph node clearance, you have a gross lymphedema on the ipsilateral arm. So can you have a lot of mediastinal nodes and the cardiac lymphatics drain into the mediastinal nodes? Subcarinal nodes drain the infrabasal area and different areas preferentially drain into the lymphatics. So my question is, if there is a primary lymph nodal disease, the myocardium, can it be secondary?
I did not get your question completely, but yes, if we do see typical lymph node enlargement, and even if we do not see cardiac involvement, we usually complement it with a non-contrast HRCT. And if we are seeing, say, lung changes and lymph node involvement, which is typical of sarcoid, we report it as sarcoid. But obviously, cardiac involvement, we will not say it as cardiac involvement. I think that is what you're saying. Cardiac involvement manifesting as lymph node enlargement.
No, pathologically, what I'm asking is, suppose you have a gross lymph node enlargement and the lymphatics of the heart are draining into the lymph node, subtended lymph node, and the lymphatic pressure is high, what will be the change in the lymphatics? Cardiac lymphatics, are these imaging findings some of the subtle changes that you see?
No.
Could it be because of the lymphatics draining, cardiac lymphatics draining into the subtending nodes?
This is something which we cannot say on radiological imaging.
Oh.
Because
are there any traces, Sharmila?
No, I don't think radionuclide imaging would help there. I'm wondering if your question was leading into, does T2 weighted or T2 mapping on MRI identify more water in the heart from the backup of the lymphatic pressures? Radionuclide at this point, I don't think there's anything we can really, but it's a very interesting thought though. I hadn't thought of it that way, but very interesting thought, yeah. So Dr. Narasimhan, I have a question for you. Are you using any of the newer anti-inflammatory agents for your sarcoidosis patients?
Yes.
What is your standard therapy? So let me ask you the other way around. How do you treat these patients medically? What are the medicines you're using?
So standard therapy is upfront, start them on prednisolone with methotrexate on day 1. And at the end of 4 months, if there's a good response, we rapidly taper off the steroids and continue methotrexate for 2 years. For patients with extensive involvement, more than say 3 or 4 segments, or patient has LV dysfunction, we are now upgrading straight away to biologicals like infliximab or adalimumab. We are not going through this sequential thing of giving prednisone first and then waiting for a response, because there's very little time for us. So we are trying to bring in biologicals early on in the course of the disease. Of course, third one is for refractory patients who have failed to respond to initial therapy. We start bringing in, either for patients who can afford, we use biologicals. Patients who can't afford, we use intravenous cyclophosphamide.
Okay, got it. Thank you. No, that's very clear. That was my specific question. When are you initiating biologics? And I think with an aggressive form of disease, you're kind of trying to start it earlier in the course.
That's right.
Excellent. Thank you.
Thank you for the great talk, Dr. Priya. Now I invite Dr. Muthaiya Subramaniam, So he's consultant cardiologist and electrophysiologist, AIG Hospitals. So he'll be discussing on management of granulomatous myocarditis. Over to you, Dr. Mutaya.
Thank you. So thank you to Dr. Sharmila and Dr. Priya for joining us today. I think we learned a lot. And I'll just be explaining maybe our approach to management of these patients and highlight some of the gray areas that are still remaining despite all of the recent evidence. So just to highlight some of the dilemmas that we have when we manage these patients with granulomatous myocarditis, I thought I'd just show a small case first. 47-year-old male, recurrent VT, and this is a rather typical presentation for these kind of patients with a preserved LV ejection fraction, and we can see an ECG that shows a monomorphic VT. So given his age...
Dr. Sunita, we can't see his slides as full, on the full screen.
1 second. Let me see.
I think you're sharing your screen. I am able to see the slides, but they are seen in only 1/4 quarter of the screen. Can you see now? No, see the slides are seen. That's there, but it's only 1/4 of the slide.
Yeah,
I don't know.
I also have the same problem.
Same with everyone. I mean, no. It's not seen. Dr. Narasimhan also not.
Speaker view.
Just see your settings. You can just double click the image so that you can see it. Can you see it now?
No, dear. He is seen along with his slides on 1/4 of an image. No. He's not seen.
Can you disconnect the thing? Just show the slides. Maybe it'll be bigger. Just 1 second.
Make it full screen.
Is it better now?
No, Dr. Sunita, what?
Yes, now it's better actually. It was better early. Just a minute ago, it was better.
Yeah, but still the slides are seen only in 1/4 of the screen. I don't know what is. We still see ourselves, our names written there.
You need to. You want me to present from that? Any different now?
No.
Yeah, this is fine. Now it's fine.
It's okay?
Yeah, it's good.
Okay. So, so a 47-year-old with monomorphic VT, normal coronaries, an FDG PET showed patchy, intense inflammatory, high inflammatory burden. Showed mediastinal lymph nodes. We went ahead and did a lymph node biopsy, and this showed non-caseating granulomas, and our original diagnosis based on this was a cardiac sarcoid. And the first management dilemma is often at this point, especially when we treat patients in an endemic country for tuberculosis. So is it sarcoidosis or is it tuberculosis? And as I'll be showing in a few slides, we often have a panel of investigations where we try to rule out active tuberculosis in these patients. And the TB culture for this patient was positive. So it was positive for Mycobacterium tuberculosis. So a diagnosis of tuberculosis myocarditis was made. And this is a very important diagnosis to make because it alters the treatment regimen the patient receives considerably. Given the history of a VT, a single chamber ICD was implanted, patient received ATT and steroids, and we can see complete clinical and radiological resolution of the disease. Patient was arrhythmia free for the last 7 years. He's doing well. We do an EP study just to make sure the VT is not inducible because the ICD battery had run low. So we have not replaced the ICD battery, and he's still doing well, and this is now the 8th year of follow-up. So there are many different aspects of management of these patients. I think, so I've just chosen a few that I feel are maybe the most important or the most crucial, at least when it comes to decision making. So I'll be talking about immunosuppression, our regimen, how we assess response to immunosuppression in these patients, establishing a diagnosis and then management of tuberculous myocarditis, management of ventricular arrhythmias in the setting of inflammation, and prognostication of outcomes briefly. So immunosuppression, one thing we need to understand is that it's often a risk versus benefit, especially in treating any kind of disease that requires intensive, prolonged immunosuppressive therapy. We often talk on one side regarding benefit of the patient's symptomatic improvement, but we always run the risk of dangers of immunosuppression, especially prolonged immunosuppression in terms of infections and drug toxicity as well. So keeping this in mind, like Narasimhan sir mentioned, steroids are the cornerstone of therapy. We try to have earliest initiation of steroids as possible as soon as we reach a diagnosis. Steroids have been shown to be effective in patients with cardiac sarcoidosis with active inflammation. That's the key word, that in patients with active cardiac inflammation, steroids are essential. There is data that shows that the AV conduction disease can recover, the LV function can recover, but the main problem why we have not been able to establish any real baseline on when and how long to start steroids is there's really no randomized study data available. And the problem here is the disease itself is a dynamic disease, and the heterogeneous nature of the patients makes sure that we are not able to reach conclusive evidence based on large observational data. And one of the big issue or uncertain domains is still that the dose, the type of steroid therapy, and the duration of therapy often remains uncertain. And we often have, even in terms of oral steroid therapy, it appears that not all steroids are equally efficacious. So this is some data that has been taken from a group of studies in pulmonary sarcoidosis, just to show the difference between prednisolone and methylprednisolone. The tissue penetration with methylprednisolone appears to be more than prednisolone itself. So we have slowly adapted to, even though this data is not available for cardiac sarcoid patients itself, we've slowly adapted to using methylprednisolone over prednisolone in terms of initiation and maintenance steroid therapy in these patients. Before I get to our drug regimen, just one mention on identification of steroid resistant cardiac sarcoidosis. This is very important because we are seeing more and more that some patients, either initially or somewhere later onwards after we start therapy, show steroid resistance. And the idea is to clinically and radiologically recognize this steroid resistance is very crucial, because the earlier we recognize their resistance to steroids, the earlier we can switch or intensify the immunosuppression. And possible reasons for the steroid resistance is one, that there may be differential concentrations of steroid in the myocardium and lymph nodes, and sir had alluded to this possibly, and also that the patients may have a lower inflammatory burden at baseline. That is, that there is not much inflammation itself to treat with steroids at the beginning. So early recognition of steroid resistance patients is important, and it has therapeutic implications. And when we talk about steroid sparing regimens, there is a paucity of data regarding the choice of your second line immunosuppression, but it is a consensus that steroids alone may not be the best therapy option for a patient with cardiac sarcoid or granulomatous disease. We have tried methotrexate. Our preferred second line agents, as I'll show, is methotrexate, but we've also used MMF and cyclophosphamide when we have needed to intensify immunosuppression in these patients. And this was a study in 2019 where and I'll come to the adalimumab and the biological part, but methotrexate with a low dose prednisolone, it was able to radiologically resolve 60% of disease. So, and there is also evidence that your use of a second line agent such as methotrexate may reduce the amount of steroid resistance that the patient may have. So our institutional protocol for immunosuppression: once we have a patient diagnosed with cardiac sarcoid, PET positive and biopsy positive, we often start prednisolone or an equivalent dose of now methylprednisolone of 0.5 to 1 mg per kg per day. And simultaneously we add methotrexate 10 mg per week, and that can be increased up to 20 mg per week. And again, these dosages, there's a range for a reason, that it is tailored according to that patient and what we feel is clinically applicable. We taper and stop the steroids over a 12 to maybe 16 week time span of 3 to 4 months, and we repeat a PET scan at this point in time. And the idea here is we're trying to look for two things. One, we're looking for a clinical response, and second is we're trying to see if there's any residual FDG uptake. If the patient has clinical response and no FDG uptake, then we continue with methotrexate for 2 years and the patient no longer uses steroids. The second group is there is some clinical response, but there is still residual FDG uptake. Here we need to intensify the immunosuppression or consider the use of biological agents. The third group is where there is no clinical response and there is no residual FDG uptake. This often represents a burnt out state or a burnt out disease, and we often have to discuss advanced treatment strategies that I'll show you. So close follow-up is crucial for these patients, especially after we start them on immunosuppression. We have our patients visit every 2 weeks for the first 3 months, every 1 month for the next 6 months, and once every 3 to 6 months thereafter. And I think one of the main things we have found advantage, and that Narasimhan sir has started, is that using a multidisciplinary approach. Our weekly meetings are a combination of a cardiologist, a rheumatologist, and a pulmonologist, and because I feel all of their inputs are crucial when we start immunosuppression and plus minus antituberculous therapy as well. And the other thing that we need to do is that we are very much dependent on our nuclear medicine department and infectious disease department for management of these patients, because it is often, because as I think the first two talks alluded to, it is a diagnosis that is 99, we're predominantly picking up this disease as a imaging finding. So we need to know these imaging changes, and our nuclear medicine department does a very good job at least showing us the before and after therapy scans. So the images itself dictate a lot of our change in immunosuppression for these patients. So when we monitor our patients on immunosuppression, two things that we look for. One is monitoring the disease activity, and second is looking at the toxicity of the drugs. So in terms of monitoring disease activity, we do look at constitutional symptoms, fever, weight loss. We do look at the arrhythmias, and we do sometimes use monitoring devices to monitor the arrhythmic burden, and we do use LV function assessment. Sometimes because our patients aren't affordable, we are not able to do repeat cardiac MRI images per se, like to see the resolution of LGE. So we use tissue velocities on the 2D echocardiogram as a surrogate for improvement in localized improvement within the myocardium. And when we look at monitoring, I think 99% of our focus is seeing if the patient has an opportunistic infection. Any fever, any temperature in these kind of patients, we take quite seriously. Steroid toxicity, because they do get a high dose of steroids even if it is for 3-4 months, it's still a high dose of steroids. Muscle wastings, if they are diabetics, there's often their blood sugars raise considerably, and neurological and psychiatric issues are real. And drug specific adverse effects we do see, but they are less common than steroid related effects with methotrexate, MMF, and cyclophosphamide. And assessing our response to immunosuppression. So 4 to 6 months is usually the point at which we do a repeat FDG PET, and this is the reason why we do the repeat FDG PET here is this is the point at which we have tapered our steroid therapy. Here we look for two things. One is a clinical response. So we look for their NYHA functional class to improve, freedom from ventricular arrhythmias and heart failure hospitalization. Second is we look for an echocardiographic response in terms of improvement in LV ejection fraction. And we classify the patients as 3 groups. If the patient has both a clinical and echocardiographic response and no residual FDG uptake on the repeat scan, they're a complete responder. If the patient has either echo or clinical response or residual FDG uptake, they're in a middle group that we like to call partial responders. And the people that we watch out for are these non-responders where there is neither echocardiographic or clinical response. So this is how we classified our data, and we showed that in a recent publication that our complete responders given this kind of standard immunosuppressive regimen was roughly 55%. Partial responders 21%, but we did have a non-responder rate of close to 1/4 of our patients, which was 24%. And just to highlight these patients with refractory sarcoidosis, or the so-called non-responders that we evaluated. So a lot of how we choose their next disease therapy depends on their repeat FDG PET. If there is any residual myocardial FDG uptake, they have residual inflammatory activity. If there is no myocardial uptake on the repeat PET, we do call them as a burnt out phase. And the other is not an issue, but our limitation is we don't do a perfusion scan per se along with the tracer uptake. So we use our clinical evidence of for example, LV dysfunction and a high arrhythmic burden, along with the evidence of no myocardial FDG uptake to say that the patient has a burnt out phase of the disease. So if there is a residual inflammatory activity, we strongly consider adding another steroid sparing agent, or more recently trying biological agents as well in these patients. If there is a burnt out phase of the disease, then we automatically start thinking about advanced options like assist devices or transplant. And just to highlight the role of biological agents, we do have patients such as the one shown here, where they present an incessant ventricular tachycardia. We try many of the options that are possible, including drug therapy, ablation procedures. But we had one patient who was resistant to all of these therapies, where adalimumab made a difference, and that led to the reduction in ventricular tachycardia episodes. But not all is clear regarding the use of biological agents in this therapy. There are few now large observational studies where they've tried infliximab, adalimumab in these patients. They have mixed results with regarding to their effect on LV function and arrhythmia burden. So that begs the question, are we starting these biological agents too late in these patients? And as Sir said, sometimes if it is a high-risk individual, maybe we should consider an upfront biological approach for these patients. The main thing to watch out with all of these biological agents is there is a very high chance to develop an opportunistic infection. And so these opportunistic infections are something that we look for. Another clinical dilemma we have is regarding the overlap of tuberculosis and sarcoidosis, as I showed in the first case. And the problem is here is clinically and radiologically, they can be very similar. Serological tests, we're not sure if the sarcoid antigen can trigger similar serological responses for a skin test, for example, as tuberculosis can. And histopathologically also, oftentimes it's very hard for the pathologist to differentiate sarcoid and TB. So our model is, once we have established an evidence of sarcoidosis, we do a panel of tests to diagnose tuberculosis. If the patient has a positive skin test or interferon gamma assay, we diagnose them as latent tuberculosis. If the patient has a positive gene expert or TB culture, we diagnose active tuberculosis. And why this makes a big difference is, if the patient has active tuberculosis, we treat them with a 4-drug regimen. We do consider making it a 2-drug regimen after 3 to 4 months of 4 drugs, and we reduce the steroid dose to 50 to 60% of the calculated steroid dose. On the other hand, if it's a latent tuberculosis, it's almost like a prophylactic ATT therapy of 2 drugs for 9 months, and we use the same normal steroid dose. But the thing I'd like to stress is there is still a lot of gray area regarding this area of latent tuberculosis and how to treat these patients. A few years ago, Sir had published his experience with TB myocarditis, and this is just to show that the role of TB PCR and TB culture in clinching a diagnosis of tuberculous myocarditis. So this does make a therapeutic difference. And another thing, we do see this in other organ systems, that after you start ATT, there can be paradoxical worsening of the underlying inflammation or the underlying disease itself. And it is because of an exaggerated cell-mediated immunity response. And we have 3 patients where their cardiac symptoms worsened after we started ATT. And this has really not been described in terms of cardiac tuberculosis, but this does happen, and it is maybe well explained by other organ systems as well. And just a few points on management of ventricular arrhythmias in this patient. It's slightly different than the management of ventricular arrhythmias in other patients. Here, the basis of management of ventricular arrhythmias depends completely of whether these ventricular arrhythmias occur in a patient during inflammation or they occur in a patient with scar. Why does it matter so much? So this is our protocol for management of ventricular arrhythmias in these patients. But the most important stage is right here. So if the patient is in an inflammatory stage, we recommend that steroids or immunosuppressive therapy with antiarrhythmic drugs are required during this inflammatory phase to tide over the ventricular arrhythmias, and that the response to both and radiofrequency ablation during this stage may not be the best option. On the other hand, if the patient presents with a burnt out stage where there's no myocardial uptake, then at that point, you can consider radiofrequency ablation of these patients. I think Sir had already shown this slide just to show that VT during the inflammatory phase is best controlled with immunosuppression, and that VT during the scar phase is better treated with radiofrequency ablation. So, and we had also seen that when you do radiofrequency ablation in this group A, which is the group with inflammatory phase of disease, the outcomes of catheter ablation are also suboptimal compared to the outcomes or complete success in doing radiofrequency ablation during the scar phase. Last point I'd just like to mention is that it is important to prognosticate response in these patients. Now that we have more and more different kinds of therapies available, including biological agents, we need to earlier identify patients who will benefit more or who are at higher risk of becoming a non-responder to disease. And what we found is patients with a lower baseline inflammatory burden were less likely to respond to immunosuppressive therapy. So we saw that if your EF is less than 40%, or if you have a lower combined segments involved and SUV max, you are likely to be a non-responder. So one idea is that these complete responders do respond to immunosuppressive therapy, but it is very important to now identify these non-responders early. So just to leave us with a few unanswered questions that still remain, the role of second-line immunosuppressants, choice, duration of therapy still remains uncertain. The management of latent tuberculosis, especially in India, is a big question mark still, and I think we're moving towards some kind of consensus. And in patients who are not able to do serial FDG PETs or cardiac MRIs on follow-up, whether there are any non-invasive markers that are sensitive and specific to monitor therapy, and which patients, like I said, will benefit from early initiation of biological therapy. So, thank you.
I have one question. How common you do endomyocardial biopsy? Is it for all the patients, or any, like if the diagnosis is inconclusive, then you do the endomyocardial biopsy?
So I think a few of the speakers spoke about this. The problem with the endomyocardial biopsy is the PET uptake is patchy within the myocardium. So we have tried a few cases where we have done 3D guided mapping to see the scar in the ventricle, localize the scar and try to take a biopsy from that area. That leads to slightly better outcomes, but still we feel that the endomyocardial biopsy is maybe suboptimal in these patients. It may have to do also with the presence of disease is more a subepicardial disease. So endomyocardially, you may not be able to reach granulomas in that site. I think Narasimhan sir also may have some.
I have a small
Yes,
question.
that's.
Yes, sir.
Go ahead, please.
Why can't we include a PET at the end of 6 to 8 weeks to identify early non-responders? So after initiating therapy, so that these patients can be started on biologicals quickly.
It's a very good thought, and our idea was the same, that maybe we're waiting too long to wait definitely for 3 to 4 months to repeat a follow-up FDG PET. Earlier PET would give us a clue which way they're tending towards either responder or non-responder status.
So any questions, Dr. Sharmila or Dr. Priya?
Yeah, I have no questions, but I wanted to really congratulate Dr. Subramanian. Excellent talk, really nicely, comprehensively done in terms of treatment and everything. And I also like the last question about should we be scanning these patients a little sooner, maybe 3 to 4 weeks. That's a great thought as well. Something to keep in mind. Thank you.
Thank you.
Any questions, Dr. Priya?
I suppose you're not using too much of cardiac MRI, Professor Bhavani.
Okay, thank you so much for an excellent talk, Dr. Narsimhan, Dr. Sharmila, Dr. Priya, and Dr. Mutaya. So hope all the questions are answered. If any questions are there, you do mail us. Thank you and have a nice evening.
Thank you.
Thank you.
Thank you. Thank you.